Dear GR authors, editors, and readers, I am Iris J.M. I'm a medical doctor and researcher at the Erasmus University Medical Center in Rotterdam, the Netherlands. Together with my co-authors and colleagues, I've set up a pipeline for pancreatic juice collection and analysis in our departments, with the aim to detect pancreatic cancer in an earlier curable stage. This issue of GI Journal, we will publish our manuscript on protein biomarkers in pancreatic juice and serum. In this video, I will tell you more about the pipeline and summarize the main results of this manuscript. As many of you know, pancreatic cancer is related to a poor prognosis. Data show that the incidence still closely parallels mortality due to late presentation of symptoms and lack of effective therapy for late-stage disease. Likely, the best way to improve pancreatic cancer survival is by detection of pancreatic cancer in an early resectable stage, or the detection of high-grade dysplasia. This is a precursor lesion. Aiming for early resection, surveillance programs have been set up for individuals with suspected neoplastic cysts and those with a hereditary increased risk. These groups are being followed for 6 to 12 months, depending on the duration of surveillance and the presence of worrisome features. Unfortunately, these surveillance programs have led to resection of abnormalities which prove to be benign upon histological assessment, causing unnecessary harm. For instance, this table shows an example of 3 larger cohorts with individuals with a hereditary increased risk from Leiden University Medical Center, Johns Hopkins, and Erasmus University Medical Center, being followed on an average of 53 to 67 months. Around 3 to 4 of these participants developed pancreatic cancer. Of these, only 10 to 33% had early stage disease, which is considered as a success of surveillance. And thus 70 to 90% were not successful. A second group that can be considered as a success, as was previously mentioned, is the high-grade dysplasia group, which was 0 to 2% of participants. 3 to 7% underwent surgery and appear to have low-grade dysplasia or benign disease. For those with benign disease, we are sure that surgery has caused unnecessary harm. For those with low-grade dysplasia, it is unknown if these patients would have developed pancreatic cancer if they were not resected. We are in need of a diagnostic tool which is able to complement imaging by decreasing the number of false positives, but also increase the number of true positives. For implementation in a surveillance program, we aim for a specificity of above 95%, which could reliably postpone surgery in individuals with indeterminate features on imaging or reduce surveillance frequency in individuals without relative or absolute indication of surgery, and could this way reduce harm to surveillance. Biomarkers hold promise, as structural cellular changes are expected to occur months to years before a lesion becomes even apparent on imaging. Thus, biomarkers may complement imaging in ruling out malignant disease. Many blood-based markers have been investigated in the last couple of years. However, for surveillance purposes, these biomarkers have not lived up to expectations due to high false positive rates. As multiple subtypes of pancreatic cancer have been identified, each potentially characterized by distinct biomarkers, it is expected that a combination of biomarkers, rather than one biomarker alone, is needed to reach such a high specificity. Pancreatic juice is a promising biomarker source. It can be stimulated easily and safe by intravenous infusion of secretin, as compared to either pancreatic juice collection by pancreatic duct cannulation via ERP or with tissue sampling with fine needle aspiration or biopsy, secretin stimulated pancreatic juice collection from the duodenal lumen is less invasive. Biomarkers determined in juice are expected to be more pancreas specific, as this fluid constitutes a washout of the pancreatic ductal system and has been in close contact with the ductal cells from which pancreatic cancer originates. Additionally, in contrast to needle biopsy, pancreatic juice collection does not rely on a visible mass, and pancreatic juice potentially contains information on the complete range of tumor clones. Downsides are that endoscopy is needed, and pancreatic juice consists of enzymes which are able to digest pancreatic juice. So pancreatic juice should be snap frozen immediately after collection. In our research line, we first set up multiple case control studies to identify the most valuable biomarkers. In this study, we aimed at developing a biomarker panel that is able to distinguish individuals without pancreatic cancer in order to avoid unnecessary harm to participants in a surveillance population, while also detecting pancreatic cancer with considerable sensitivity. To this end, we investigated the diagnostic performance of 5 biomarkers in both serum and pancreatic juice and compared these biomarker sources. Additionally, we evaluated the performance of CA99 in serum. We included 59 individuals with pancreatic cancer and 126 controls undergoing pancreatic surveillance in Erasmus University Medical Center. All these controls had suspected neoplastic cyst or a hereditary increased risk of developing pancreatic cancer. We compared the concentration of these markers between cases and controls for both serum and pancreatic juice. And we evaluated if markers were associated to pancreatic cancer independent of age, gender, and the presence of diabetes mellitus. At last, we performed the sensitivity analysis to evaluate the performance of each variable and all variables together in a panel. This image shows the anatomy of the organs around the pancreas: the stomach, the gallbladder, and the duodenum. You can also see the endoscope. During pancreatic juice collection, the tip of the scope is kept close to the ampullary orifice. In this video, a juice collection is shown, where we collect pancreatic juice in a person with a hereditary increased risk of pancreatic cancer. No morphologic changes were previously seen by endoscopic ultrasound or MRI. In the video, the ampulla can be seen at the left side of a catheter in the right upper hand corner of the video. If you look really closely at the video, you can see it opening up, excreting pancreatic juice, which is a transparent fluid. It is important to not enclose the ampulla with any device, as it may induce pancreatitis. In the current study, after insertion of the tip of the endoechoscope into the D2 segment of the duodenum, suction through the endoscopic channel was performed, not via the catheter that is seen on this video. This is based on previous results of our group. We started collection immediately after injection of secretin for 8 minutes by positioning the tip close to the ampullary orifice. Within 10 minutes after collection, juice was aliquoted and snap frozen. Samples were stored at -80 degrees until use. As expected, cases were older of age. 61% of cases were males, Additionally, cases had a lower BMI and more often had diabetes mellitus. While the total protein concentration in blood was not higher for cases than controls, the concentration of CA99 and interleukin 8 was higher for cases than controls. For other markers, the concentration was not different. However, logistic regression showed that only CA99 was associated with pancreatic cancer, independent of gender, age, and the presence of diabetes mellitus. For pancreatic juice, concentrations of interleukin 8, interferon gamma, NGAL, MUC5AC, and MAC2 were higher for cases than controls. Only for interleukin 8, NGAL, and MUC5AC, these markers were associated to pancreatic cancer, independent of age, gender, and the presence of diabetes mellitus. For the pancreatic juice markers that were independently associated with pancreatic cancer, cutoffs were selected aiming for high specificity and were based on the RC curve that can be found in the manuscript. For CA99, a cutoff of 37 was used, as is seen in this table. Interleukin 8 in a pancreatic juice had the highest specificity of 92%. With a sensitivity of 45%. CA99 has the highest sensitivity of 7%, with a specificity of 85%. A panel of 4 markers had a sensitivity of 42% and a sensitivity of 96%. This panel performed significantly better than each pancreatic juice marker alone. In conclusion, in a case control study of 59 cases and 126 controls undergoing surveillance, we selected 1 blood-based marker, CA99, and 3 pancreatic juice markers that were independently associated with pancreatic cancer. A panel of these markers has a sensitivity of 42% and a specificity of 96%. However, future prospective studies are needed to validate this panel in a longitudinal surveillance cohort where we collect consecutive samples. Additionally, we need to investigate if combining these markers with morphological changes on imaging or DNA markers like p53 leads to an increase of sensitivity and allows earlier identification of pancreatic cancer. Biomaterial in this study was collected as part of the COSPANC study and the local branches of the Pacific and the CAP study. I also would like to acknowledge and thank my co-authors, predecessors on the Pacific and the CAPS projects, and the medical students who helped us out collecting pancreatic juice over the last couple of years. At very last, thank you for watching this video today. Please send me an email if you have questions about the manuscript and this video. Thank you so much.